Well, I'll just have to echo what Laura and Mary have already said because I agree with what they've said, and I might can add one more thing to it, is when we're looking at the spread of where it needs to be, we need to have these programs. I think we ought to look to our employees, perhaps our employers, to provide this as a benefit, as I mentioned earlier. But what can we do to help those employers when they're struggling economic client? Maybe a tax incentive or some kind of tax break, especially for your small businesses, to be able to provide this for their employees as a benefit, a standing benefit. And even a menu of services, if you would, because not every caregiver needs the same amount of intensive caregiving programs, but we have enough programs from early stage to late stage that I think a nice menu of services could certainly benefit all employees and all of our caregivers and receivers.
Okay, at this point, we have about 40 minutes for interaction between participants and panelists. So I think we have a first question.
I don't know if it's a question or comment. I heard you talk about a little bit about employers, but I want you to think of caregivers as someone like me. I'm in my early 40s. I have very young children at home. I just buried my dad from Alzheimer's. My mother has moderate. And I am managing kids, a job, and a mother. And then should I get Alzheimer's, my kids will likely be in their 30s when they have to manage me. So how do we deal with people like me who are in the sandwich generation, who have their own families, and then they have their parents that they have to care for because their spouse isn't available, their siblings are dead, or whatever. They don't have anybody. And by the way, Alzheimer's is very isolating. So for my mom, she was my dad's caregiver, and then as he was ending his time with Alzheimer's, and at the end of her life, they become so isolated, she dropped all of her friends. So now, so she doesn't have anything. So, it's kind of like it falls back to the kids.
I'll start this, and then y'all can add in on that. I'm hearing that you're an adult caregiver of your sandwich generation. Personally, I'm there with you, but
But I think you're going to see that more and more. It's going to fall more onto the adult kids
right
in the future generations of Alzheimer's.
And we were tracking that in our evidence-based programs and looking to see how many of them were adult children. And some of it, and it's anywhere from 59 to 75%. So you're exactly on target with that. And if they're still working, I think the example you gave, they're still working. They're going to need some kind of support because the stress is just tremendous. But one of the great things of these programs is they do decrease the stress, and they teach them, like for REACH, the signal breath. They teach them how to go in and manage this stress, and then also your resources, where to reach out to. So many people today, as I'm working, I'm not sure who to reach out to. I don't know what my resources are, but the programs that we've worked with are both empowerment programs that teach you how to do that, how to manage that stress with good results. And I'm just going to start.
So I'm going to ask one more thing. I'm going to put on my payer hat now. So as you're thinking about how you pay for these programs, I also think you want to think about from the CMS, from the Medicare side, what is it going to do in terms of cost for the patient with Alzheimer's or dementia. But the other side of it is you're going to need to figure out what's it going to save money for the caregiver who is not Medicare yet, and so you're going to have to go back to commercial insurance, Medicaid, or whatever, and see is it preventing what is it doing in terms of going into that, into even their medical expenses. So I think that's going to be how you're going to have to present the business case. You're going to have to show both sides.
Yeah, good. No, I think you're right. I mean, just one question for you. I mean, did your doctor? I'm not trying to medicalize caregiver interventions, but did your doctor ever ask if you're providing care? Because if they did and you are, then maybe you should be monitored differently and referred to the programs that are represented here. So in terms of a system of care, that would be one way in which a non-pharmacologic approach is integrated at a very early stage when, you're right, more and more, and you mentioned that in your, are caring for many different kinds of situations, but that's not part of standard care. And so that's where it has to begin in one place. The other question you raised, I think, is very, very important in terms of payment, but then again, where are we putting our dollars? So there's more and more and more evidence about, I'll use the term non-pharmacologic, and we don't have an industry for non-pharmacologic. We have an industry for pharma only. So maybe the care has to be turned on its head, and we don't, we have a reimbursement system that equally pays for these kinds of programs that are non-pill, and that do take maybe face-to-face, if it's in the doctor's office or at home. But in the long run, may prevent a heart attack or may prevent, other kinds of stress-related diseases. So I think that's how we do need to begin to think about these things. And it has to be a much more integrated approach with traditional medical care. I think it has to be turned around in that respect.
Well, I would just like to add to what Lisa said and what you said before, that the employer has a real incentive to maintain the health of his employees or her employees. And I have several caregivers working for me, and because I couldn't possibly tell them that they have to come to work no matter what and on the same hours no matter what. But in fact, if I weren't flexible, they would either have to quit their jobs, or they would certainly have reduced pay because they have to be out. They have to run to take care of mom, then they have to run and get the children from school, and they're juggling, and yet they want to work. So I think the employer not only has to provide these services as a benefit would be very nice, but also understand that in order to maintain their employees who are multiple caregivers, they have to be flexible in the hours that they allow people to work, and encourage them to work when they can instead of lockstep like everybody else at the same hours.
Or provide these interventions during lunchtime or after hours, or offer it as a benefit.
Yes.
It could be easily integrated in terms
Yes.
of an employee benefit.
I'd like to just follow up a little bit about the last speaker, and that is, having had the long view of this for 30 years, the caregivers that come to us have totally flipped over. It used to be predominantly spouses, and now they're adult children. And that's just the reality. And so when I look at these interventions, mostly it's dyadic, and mostly it's spouses, not exclusively, but a lot of it is. And that the standard of practice, at least in our social work practice, has changed. Because when you're dealing with adult children, you're dealing with not one, but maybe multiple personalities. Sort of like spouses circle the wagons, so to speak. But adult children, everybody plays out their role as how they sat at the dinner table. And so the skill sets that are there on clinical practice are actually skill sets that I have to tell you are not readily, people don't come to us fully formed. And that is that they're dealing with multiple conflicting points of view of what the family needs, and you have multiple siblings if that's the case. And so your skill set is around coordination, communication, and sometimes mediation. And that we have to get out of thinking about these interventions as being strictly dyadic, but treating the family as a unit. And I think there's going to be, this is the way that I see in the future, because those family members who quit, and that's between 18 and 22% a year, who reduce their hours of employment or quit altogether, are most likely women who are making $40,000 and under, do not have the flexibility of being in a professional environment. And so they're leaving their healthcare insurance, their Medicare credits, their retirement plan, all the things that go along with standard employment. So we have to think about this in an entirely different way. Modify the modify the interventions to be deliverable in alternate formats, because you're dealing with 40 to 60-year-olds. I mean, they do actually use the internet and Skype and Google Meetings. And I mean, we've done, family meetings internationally because people don't always live in this country. So I think we have to look at these interventions as not being long-term investments going out for 8 to 10 home visits. These are working people. They don't have the time, for 8 to 10. We've had to shorten and abbreviate a lot of our interventions in order to adapt and meet the needs of exactly what you were talking about. So I just wanted to make that, that point. The practice has really kind of changed at this point, at this juncture.
Well, actually, you brought up something that's certainly been at the, something we've been thinking about, because the NYU Caregiver Intervention has family meetings as an essential component. And when we brought it to the community, we encountered some of the things you're talking about, which is that the family members have lots of other things that they're doing, and to get them together at the same time, forget about the same place, but certainly at the same time, is sometimes a challenge when they're working and taking care of small children. And we've had to be flexible in when we deliver the intervention and make it available evenings and weekends, and have the staff that's willing to work those hours in order to accommodate those needs. Another thing that's a challenge in terms of delivering the intervention is that most clinicians are not used to dealing with families. They're used to dealing with one or maybe two people at a time. And to hold a whole family in the room is another kind of challenge.
No, I agree.
To speak to the issue of modification, in our translation of the REACH 2 intervention, we have had numerous families in which multiple members of the family are in caregiving roles and enroll in the intervention and receive the intervention. And initially when that happened, I thought, oh no, that's not the way we did it. You have to identify a primary caregiver, and we only work with one caregiver per care recipient. And we quickly learned that no, that doesn't make sense in the real world. And so we do that now because the REACH intervention really doesn't have the family component that Mary's does. So in some ways, it's really brought to light the needs that are so diverse that some families would do much better in Dr. Middleman's intervention, others maybe in other interventions, and the needs vary so much. So maybe I was going to ask Laura, but maybe others to answer. How do you address the level of risk in terms of what people need? The family that was described back here sounds like that's a pretty high risk family with very specific needs. We find some folks who are just kind of happy little old ladies caring for their husbands and just couldn't be happier in this role in life. Particularly, Laura, I'm going to address it to you. How do the OTs get to that, and how do the home health companies really look and say, this is somebody who is in high need, let's get them some extra care?
I think one of the beauties of skills to care, as well as many of the other interventions that have been discussed, is that they are tailored. So that is really, I think, what we've learned from this whole body of research, that it must be tailored to, families can't really deal with issues that may happen 15 years from now, or 10 years, or even 1 year. They really are very focused on managing what their issues are at the moment. And so tailoring, in a way, allows for that kind of risk appraisal, if you will, and then a decision as to how much education or how much skills or what areas need to be addressed. So I think that addresses it in one way. In working with home care agencies, we were surprised that many do not have very basic protocols, so that most therapists, nurses, OTs, PTs do not have the skills to assess for depression. And when you assess for depression, you have to be willing to, which is a big risk factor, and that's why I mention it, for caregivers, so that if you assess for depression, you do have to be prepared to manage that. So in training and working with home care agencies, we have had to provide suicide protocols. We've had to train in depression. We've had to go out beyond even what the intervention is. So we have also changed skills to care by adding certain risk assessments because they were not systematically being assessed either in our program or by the home care agency, and then help the agency, put in the necessary referral mechanisms. And then we also do a lot of staff training so that everybody understands the kinds of referrals that may be necessary. So you do have to step beyond what was initially tested to adapt to, all these different environments and, Kathy's point of changing family dynamics.